Thank you for the presentation. Good morning, everyone. It's an honor for me to present in front of you. Please, next time, Dr. Walid, let me present in the beginning because it's very hard to present, especially after many experts and good presentation. So today we're going to talk about rewriting the script, myopia, from myopia correction to myopia prevention. It's very important before we start the presentation to remind ourselves and the patients about the importance of ocular health. So our ocular health is as much as important as our systemic health. I read once a study that shows if you are now able to stand on 1 foot from a seated position, you will be most likely able to walk by the age of 70. And very important to, you can try it as well. So why myopia nowadays is a global concern? Because as you can see, any myopic child is a potential candidate since studies have shown that there are no safe levels of myopia. So why myopia is always a concern? As you all know, now myopia is becoming an epidemic. So by 2050, half of the human population until now will be myopic. So by then, of course, I think the number will increase more. So as you can see here on the slide, even low myopia can be a risk factor for many patients. So even low myopia will double the risk of having cataract, triple the risk of having retinal detachment, and double the risk of having myopic maculopathy. So when we talk about myopia management, it's important to list the risk factors. And when we list the risk factors, it's important to divide them into two parts. We have the modifiable risk factors and we have the non-modifiable risk factor. Of course, the non-modifiable risk factors are the age. So the younger the onset, the age of onset, the faster the myopia progression. Myopic parents is very important to take it into consideration. So genetic is very important. Having one parent who is myopic will increase having myopia by threefold. Increase the outdoor time. So outdoor timing is very crucial for myopia management. Now we are into the modifiable risk factors. So outdoor time, close work, and very important as well to mention the binocular vision status when we treat and when we manage myopia. So it's very important to talk about axial length change. We all know that the diopters are easily measurable, but myopia management is all about axial length control and axial length change. For example, in emmetropes who doesn't have myopia, the normal axial length change between 7 to 10 years old should be around 0.1 to 0.1 millimeter per year. For uncorrected myopes or for myopes, the progression will be faster and the axial length growth will be more than 0.1 to 0.2 millimeter. And this is really important to monitor it and to timely control it. So to be honest, we are blessed to work in a country where we have all the interventions available for myopia management. So what are the interventions? We surely have the ophthalmic lenses, the next generation ophthalmic lenses. Now we have newly the contact lenses. We all know the multifocal contact lenses, dual focus concentric designs. And now newly we have introduced the extended depth of focus contact lenses that will correct and will treat myopia. We have the famous Ortho-K, and last but not least, we have the pharmaceutical agents like atropine. So just to start briefly about the optical treatment, many studies or many animal studies have shown that altering the visual stimuli can alter the axial length, and many various powered ophthalmic lenses, plus and minus, can either shorten or lengthen the axial length. And we all know that the peripheral portion of the eye is more important into myopia management more than the central part of the retina. So here is an optical myth. So under correction on progression, on progressing myopes, so many randomized clinical studies have shown that 0.5 to 0.75 diopters under correction may speed up the progression of myopia. So we should always take that into consideration whenever we are addressing a patient with myopia. So the management study is a treatment program to keep the level of myopia as low as possible by slowing down the axial length elongation, which will reduce the children's risk of having many ocular related pathology later on in the life. So as we all know, the aim first is to correct myopia and to treat or manage myopia. How we do it? We all know that minus lens will bring the light into focus on the central part of the retina. But what will happen on the peripheral part is that we will have a hyperopic defocus. And this hyperopic defocus will trigger a biochemical signal on the retina that will make the eye elongate more and more. So what will happen is that we will have a next generation of ophthalmic lenses that has a correction zone in the central part and a treatment zone on the peripheral part. This correction zone will bring rays of light into focus, and on the peripheral part we will have a myopic defocus that will trigger a signal on the retina to stop elongating. So this is how these next generation glasses will work. So we have many brands that are integrating these type of technologies. Next, we will talk about the soft contact lenses. Of course, you always know about multifocal and dual focus contact lenses, but nowadays we are proud to launch, we have the blessing to launch a new contact lens that will work on the extended depth of focus. So centrally, it will correct myopia, and as you go away from the center, the extended depth of focus channel will really create an aggressive myopic defocus that will stop myopia from progressing. And here on the Hartmann-Shack aberrometer, you can see the profile of the lens itself. So we'll have a pinhole effect. It's an optical pinhole that will correct myopia centrally to have the stereopsis needed, and on the peripheral part will induce the myopic defocus to stop the axial length progression. Luckily, this lens will cover astigmatism up to 2 diopters, which is very good for our patients who have astigmatism. Another treatment is atropine. You know that atropine can be the front runner of myopia management. So atropine can be the front runner of myopia management. And as per the WHO, for children who are aged between 6 to 10 years old with at least 1 diopters of myopia and 0.5 diopters progression per year, atropine is recommended for them. The dosage is usually the lowest, depending on the age, the progression, the lifestyle, and of course the ocular health. And we cannot talk about myopia management without mentioning Ortho-K, the famous Ortho-K. Okay, it's an invasive method, but it's very efficient. We should always take into consideration the ocular health, the lifestyle of the patient, the age, and the level of education of parents, which is very important. For me, it's very important to consider the efficacy of the treatment, the safety, the distance acuity, the near acuity and accommodation, and the budget of the parents as well. And not to forget, the simplest advice that we need to give our patients and the parents is the outdoor time spent by the children, because you know the natural light will trigger the release of dopamine, which will regulate the growth of the axial length. So avoid brightness, avoid dim light, so have a balanced ambient light. Thank you so much.
Thank you very much for the lecture. Any questions from the audience?
Thank you for the nice presentation. My query regarding that, as you discussed in this one, that undercorrection of 0.5 or 0.75 may speed up the progression of the myopia. Yeah. So, as we understand from your chart that the peripheral you are giving in the myopia correction lenses, the peripheral is lesser, like there is plus power.
Exactly.
So, if we are giving undercorrection, how does it accelerate the speed and the aggression?
Yeah, it's a very important question, to be honest. Thank you for mentioning it. So when we talk about myopia management, it's the goal first is to correct myopia. This is the first goal that we aim for. The second goal is to control myopia. How we control it? First, by fully correcting the patient, checking his binocular vision. We should always in the next generation spectacle lenses, you have the central zone which will correct myopia, and on the peripheral zone you will create a myopic defocus. It's a progressive plus power that will create a myopic defocus. But this myopic defocus is only done on the peripheral part of the retina, not on the central part of the retina. And peripheral part of the retina is more important when it comes to myopia progression than the central part of the retina. When we do undercorrection, we might first be compromising the quality of life of the patient, and we might be interfering as well with the accommodative facility of the eye as well itself. That's why when we choose for example, when we talk about atropine, it's very important to choose the dosage because, you know, it's a muscarinic inhibitor, acetylcholine inhibitor, so you must take it into consideration.
Yeah, one more question. You said undercorrection is a threat. What happens if they overcorrected?
It will be worse as well, because rays of light as well won't focus on the central part of the retina. And when we do as well the treatment for the myopia management, peripheral rays of light will focus on the retina. That will maybe create a hyperopic defocus. Yes. So fully correct.
I just want to ask any of the doctors here or practitioners or whatever optometrist is doing using these anti-myopic glasses for squint cases. So anyone is using for strabismus?
Yeah.
No, I'm asking about strabismus. Anyone having strabismus is going to have this? Anyone using for strabismus patient, intermittent exotropia, anyone like that? No. I mean, anti-myopia lenses.
Just
Is using
yeah.
any type of anti-myopia lenses or spectacles. The glasses, the anti-myopic glasses, or atropine, or any of the measures of anti-myopia.
We're using the lenses which has
For strabismus patients. He is a strabismus with myopia.
no, for myopia, and also maybe for strabismus or no strabismus, it will delay the progress. I mean, this is what I'm talking about.
For strabismus,
will improve the strabismus.
it is very, very risky.
Very hard to.
It's very risky. It's very risky.
If we are undercorrecting, so especially there was a thing that is the give a little more.
Sure.
For intermittent exotropia, I haven't seen it working. The glasses do not make a difference. That if you try to give them something what we are discussing, no, it doesn't work. Intermittent exotropia is a surgical disease, in my humble understanding, and if you're talking about intermittent.
Yeah, my recommendation from my experience that for the era of the anti-myopic lenses, which is everywhere and the atropine is everywhere, with the debate if it is useful for the myopia or no, I'm not going to go for this, but for strabismus patient, don't use that, please, because you are breaking. Yes, sure. So sure. We are now closing, and just because you are blocking the peripheral fusion and you are going to affect the binocular vision, and it is not at all recommended for the patients. Thank you very much for all your attendance, and thank you very much.